Good morning, friends. Today we have a special presentation on a very common topic, which is that when you are doing a lap chole, if the calot triangle is not normal, it's not virgin, you don't have clear planes, so it is a difficult calots how to deal with it. And all of us who work, at least in North India, uh, where patients usually come to us after a long duration of history of symptoms or repeated attacks of acute cholecystitis. This is a very, very common situation, very common problem that we face. A difficult calots is one of the reasons or one of the causes of a bile duct injury or bile leak. So it's very important that everyone, every general surgeon, every minimally invasive surgeon, every GI and HPV surgeon should know how to tackle a difficult calot triangle. And one of the best persons to handle this is Dr. Sundeep Jain, who is one of the senior most and pioneer GI surgeons, not only in the city of Jaipur, but in the state of Rajasthan. I remember many years ago, he had organized a CME and workshop on HPB topic, and where I also attended. So thank you, Sandeep, for offering to discuss this very important topic with the Jaipur Surgical Tutorial. Over to you. Thank you.
Thank you, sir, for the kind words and for giving me this opportunity to address this important, common yet important subject of difficult calot triangle. And although it seems for many that this is a very difficult thing, but actually once we go through the presentation, we will realize that it is the problem arises only if we omit few important steps in the management of in the procedure of cholecystectomy. So we will discuss all these things one by one. Good morning all. So proceeding with the topic of difficult calot triangle, and to discuss about the approaches to towards difficult calot triangle, we have to first understand the theoretical part, what are the ways to manage it, and what it takes to manage a simple gallbladder. So I will go through all these things step by step. So to make ourselves to remind ourselves, laparoscopic cholecystectomy though is the gold standard nowadays, but it is associated with 3 to 5-fold increase in bile duct injuries in comparison to open cholecystectomies. And the commonest cause of bile duct injury is misidentification of structures, most commonly common bile duct with cystic duct. And it is usually when the common bile duct or an aberrant duct is mistaken to be a cystic duct. So various modalities to undertake cholecystectomy in difficult situations include critical view of safety. We all must be aware of this term, which was introduced by Strasberg et al. In 1995. And we have now enough evidence that where CVS was achieved, bile duct injury incidence has been reduced to nil. Culture of safety in cholecystectomy called COSIC has added, in addition to CVS, few pointers like appropriate patient selection and workup, depending on the expertise of the surgeon, adjustment of surgical technique in setting of non-routine cases, use of bailout procedures, and avoidance of complex cases when appropriate experience is not available. This is very important, that patient selection with respect to the experience of the surgeon. This we often miss, maybe because of the competitive nature of practice these days. So we have to take care of this very importantly. And third is SAGE's 6-step program for safe cholecystectomy given by SAGES. Again, the most important aspect is critical view of safety. Then to consider intraoperative timeout before clipping and cutting any structure. This is very important. Once we identify all these structures, both the ductal structures, take a pause. If you have a senior person or another person, senior or junior, just make him or her have a look on this, take a pause. And then to many times what happens is you end up identifying what is going wrong there. To understand the aberrant anatomy, liberal use of cholangiography and intraoperative imaging of biliary tree, identify risk zone and consider bailout procedure when the conditions are difficult, and to get help from another surgeon when in difficulty. This is also a thing which is very, very less utilized, and it can prevent lot of injuries. If it improves the overall outcome even if you identify a bile duct injury on table. Overall management steps towards cholelithiasis patients includes pre-operative preparation, workup, selection of patient. Again, I'm re-emphasizing the importance of selection of patient depending on your or the operating surgeon's experience, operating room setup and preparation, access, exposure of the gallbladder, dissection at various levels including calot's triangle, use of intraoperative imaging, decision making and call for help, and bailout when and how. So pre-operative work, we will go all these steps one by one. Pre-operative preparation and workup include, we have to consider a few things. We have to first know the known risk factors for difficult gallbladders in the pre-operative period itself. Elderly patient of more than 65 years, male gender, morbid obesity, presence of cholecystitis, and again in acute cholecystitis, if it is more than 72 to 96 hours since onset of symptoms, raised TLC, palpable gallbladder, and gangrenous or perforated gallbladder on imaging. All these are risk factors for a difficult gallbladders. Regarding chronic cholecystitis, thick-walled or contracted gallbladder, history of more than 10 episodes of biliary colic, prior history of acute cholecystitis, and history of or presence of percutaneous cholecystostomy tubes. Presence of Mersey syndrome or cholecystoenteric fistula on imaging, cirrhosis or portal hypertension, doubt of malignancy, history of prior operations like upper abdominal surgery, previous attempts at cholecystectomy, history of partial cholecystectomy in the past, high degree of suspicion. We have to maintain a high degree of suspicion for Mersey syndrome and malignancy because these two can coexist, one, and secondly, the degree of difficulty increases significantly. And third, if these two things are suspected, we must take a consent of possibility of open procedure. We all as surgeons must be aware of the non-routine situations to stay one step ahead of the danger. So that is the key. All these presence situations, if we identify in the pre-operative period and we could think of the possible problems these things can land us up in during surgery, we can prevent almost all of them. For patients with confirmed acute cholecystitis, we must have a comfort as a surgeon to operate on these patients, and according to that comfort or expertise, we have to decide the timing of surgery. There are many methods by which we can postpone the surgery. If suppose you are in the initial learning curve and you have a severe acute cholecystitis patient, you can always wait, put the patient on medical management, or if it does not respond to that, percutaneous cholecystostomy, and then do an interval cholecystectomy. Various non-operative treatments includes antibiotics, percutaneous cholecystostomy tube inserted with delayed cholecystectomy, especially for patients with grade 3 severity of acute cholecystitis. These are Tokyo guidelines for acute cholecystitis, and I recommend all the surgeons to have a clear-cut guidelines of understanding of these Tokyo guidelines, because they help us manage these patients in a much safer way. As a surgeon, as a group, what I have seen is that we are very much reserved about this cholecystostomy procedure, even in difficult cases. And once we start practicing this, both our results and the incidence of bile duct injuries will reduce. For grade 2 patients, according to Tokyo guidelines, the cholecystectomy may be difficult, must be individualized as per available surgical expertise or the condition of the patient. Surgeons must balance risk of bile duct injury and definitive management of these patients. We all must have heard the term called damage control surgery. Depending on the severity of cholecystitis and depending on the expertise of us as the surgeon, we must first, in a habit of doing a damage control surgery, prevent the sepsis part, inflammation part, either by antibiotics or by percutaneous cholecystostomy, and then go for definitive management later on. Regarding operating room setup and preparation, surgeon must develop the mindset for preparing for the worst. Operating table capable of fluoroscopic imaging, position changes, and capable of accommodating morbidly obese patient has to be seen, and patient has to be large enough to accommodate C-arm fluoroscopy. Why this slide is there? Because many of us work in a situation where the hospital setup is small, OTs are very small in size with limited space for movement and everything. So we must take care of these things to have to manage the difficult situation in a better way. Now, regarding the access of the abdomen, standard access is the periumbilical location to put for the pneumoperitoneum and to put the first trocar. In obese patients, mind you, umbilicus moves down and the adequate distance for camera port is 15 to 20 centimeter for this fold. In these patients, we don't take the umbilicus as the landmark to put up the first port or Virus needle. Alternate sites of access has to be understood and practiced upon. In case of prior surgeries, left upper quadrant or the Palmer's point, as we know it, is the site of access. Placement, we must develop a low threshold for placement of additional trocars, mostly 5 mm. It is most commonly required for a hanging segment 4, and mostly it happens in cirrhotic livers. So it needs retraction to go access the calot triangle. And also we must put our 4 ports in such a way that there is a proper triangulation about the gallbladder. So the key to understand is that the operating instruments like the epigastric port instrument and the mid-clavicular line port for the dissection, for the retraction, the tip of these 2 instruments must form an angle close to 90 degrees. And if that happens, then you have a best possible triangulation about the gallbladder for the surgery. For the exposure of the gallbladder, we recommend angled laparoscope, either 30 or 45 degrees. Many of us still use 0 degrees, and if you must start trying 30-degree scope, it definitely adds to your ease of surgery because of better visualization. To have better visualization of medial and lateral aspects of the gallbladder, as I said, angle laparoscope does that. Then the proper positioning of the patient, which is head low and right up position. Additional port for retraction of protruding liver segment, omentum, transverse colon, as I told earlier, and it is most commonly needed in obese and cirrhotic patients. Regarding dissection, the initial goal is achievement of critical view of safety because it prevents misidentification injuries. There are 2 kinds of injuries. One is misidentification injuries, which happens to the biliary ductal system, and another is injuries to bowel, that is mainly transverse colon and duodenum. So first goal is achievement of critical view of safety, and second is to take down the adhesions to the gallbladder so as to avoid injury to transverse colon and duodenum. Always take care of presence of any cholecystoenteric fistula. We must have a high degree of suspicion. Whenever there is an adhesion between duodenum and gallbladder or colon and gallbladder, we must presume a possibility of these fistulae and take care of them while dissecting. Once we separate the adhesion, we all must always look for whether we have missed such fistulae or not. Then safe use of energy source, another very important aspect. Usually these cholecystectomies are done by using a cautery as the electrocautery as the energy source, and some few surgeons use harmonic also. So for harmonic, you have to take care of the active blood because it gets heat up and it should not touch any viscera immediately after the use. And cautery, we must take care of the transmission of current if it is not used properly. All these injuries, especially transverse colon and duodenal injuries, they are detected very late, so have a disastrous outcomes because of the inability to detect them on table. We must understand that the achievement of critical view of safety has no role in preventing injuries to the colon and duodenum. So we must take care of these two organs also in addition to CVS. Hepatocystic calot's triangle dissection, it is here that the dissection for CVS must be done. Open this triangle by retraction of gallbladder fundus towards the patient's shoulder and infundibulum laterally and down. Now, during this dissection in the initial learning curve, when we are a resident and are into our initial few cholecystectomies laparoscopically, this is a difficult part because often we forget that it is a mirror image kind of movement we need required to do these retractions. So the handpiece of the instrument has to move in the opposite direction of the desired direction inside abdomen. So suppose we have to retract the gallbladder fundus towards patient shoulder. In that case, our left hand holding the outer side of the instrument must move medially. So it has to be in the opposite direction. Medial and lateral peritoneal attachments of the gallbladder must be incised. And this is effective even in presence of severe inflammation. All dissection must be in close proximity to the gallbladder and anterior to the horizontal Rouvier sulcus, which contains the right portal pedicle. In few situations, the Rouvier sulcus gets very close to the gallbladder fossa, and we will see in subsequently when it happens and how to deal with it. Endpoint of dissection is achievement of CVS. We will discuss what CVS is. Avoid infundibular technique because it is prone for misidentification of common duct as cystic duct when the former is adhered to the gallbladder due to inflammation, and thus ends up in a classical Davidoff's injury. Mostly neglected component CVS is the freeing of the lower third of the gallbladder from the cystic plate. And here only once we free the lower part of the gallbladder from the cystic plate, only then we could identify an anomaly where cystic duct opens into variant right hepatic duct or segmental duct. So this third component is very important. Now coming to the critical view of safety, the three components include the triangle of calots must be cleared of fat and fibrous tissue without exposing the CVD. This is very important that CVD must not be exposed. In other words, it can happen only if your dissection is close to the gallbladder. So this is an important part. You must always remember to remain close to the gallbladder. The lowest part of the gallbladder we separated from the liver bed of the gallbladder, that is the cystic plate. And lastly, only two structures, that is cystic artery and cystic duct, should be seen entering the gallbladder. Once these three criteria are fulfilled, CVS has been attained. CVS is achievable no matter what the intraoperative situation is. It is achievable in standard laparoscopic cholecystectomy. It is achievable in single incision laparoscopic cholecystectomy. It is achievable in Notes cholecystectomy, and it is achievable in severe forms of acute and chronic cholecystitis. So in any situation, if we are going for laparoscopic cholecystectomy, we must achieve critical view of safety. If in any of these situations we are unable to achieve CVS, that means we are in the learning curve, and we need to learn more, and it is another indicator that we need a expert hand in OT if available. CVS in severe inflammation, it is likely to dissect the common bile duct circumferentially, believing it as cystic duct. This happens quite frequently in severe acute cholecystitis. This happens because the common hepatic duct fuses with the side of the gallbladder and thus resulting in the bile duct injury if we don't identify it in time. CVD also can similarly be dissected instead of cystic duct while using CVS. Again, because of the inflammation, sometimes CVD gets adhered to the gallbladder, but it will not be divided at this point because the other conditions for CVS have not been met. So what I mean here is that even if we are looking for CVS, achievement of CVS, it is not that if we follow the steps of the CVS and try to achieve CVS, that bile ducts will not be found adhere to the to the gallbladder. But the important part in CVS to be understood is that here we do not divide any structure until we achieve all these 3 points. So suppose we have a CBD or CHD attached adhere to the gallbladder, we will not do the division part until all these 3 things are separate. By that, we prevent bile duct injuries. So CVS, once CVS is achieved, means cystic artery has been identified properly. So if cystic artery is not identified, we don't divide anything. If triangle of calots is not completely cleared, we don't divide anything. If the base of cystic plate has not been displayed, we just don't divide anything. And that is how we prevent injuries. There are a few small videos which are not playing in this PPT format. So I am going to display all those videos in the end of my PPT presentation. So this is a picture where you can see, because of the severe form of acute inflammation, this duct, which the surgeon thought is a common cystic duct, is actually the common bile duct, and it is going like this. So this problem occurs when we do the cholecystectomy by infundibular approach rather than by displaying critical view of safety. Before the CVS was mentioned or established in 1995, the most common method of doing cholecystectomies was infundibular technique, where we used to just dissect the calots. Very small windows were created, and whatever ducts used to entering going towards the gallbladder used to divide. And in these kind of cholecystectomies, the incidence of bile duct injuries were very high. Now coming to a top or dome down approach, it may be useful sometimes, but we must make a habit to use it only in the most difficult situations. It makes the difficulties in these approaches that it makes the retraction of liver difficult because the gallbladder is separated from the liver from fundus down. It constitutes an error trap, as dissection may drift too close to the major biliary and vascular structures as you go down. In severe inflammation, cystic plate contracts, making important structures quite close to the gallbladder. So again, making them prone to injury. And in some cases, it may lead to combined biliary and vascular injuries, which is a big disaster. So we must always try to make it a point that we have to, prevent ourselves using top-down approach as far as possible. The role of intraoperative imaging, cholangiography, the routine use is controversial, and in more than 50,000 cholecystectomies which were analyzed, IOC found protective for bile duct injury in patients with history or presence of acute cholecystitis, but not otherwise. IOC is associated with higher rate of intraoperative recognition of bile duct injury with decreased mortality rates. Technique and correct interpretation is a problem with cholangiography in initial learning curve, and it is very important to identify things, what they are. Visualization of cystic duct, CHD, CBD, left hepatic duct with sectoral ducts and duodenum is essential to achieve adequate cholangiography. So this is very important. Whenever we end up doing intraoperative cholangiography, we must identify all these structures properly. ICG cholangiography is also in use nowadays. It is safe, but is still not shown to reduce biliary injury. Ultrasound intraoperatively is difficult and has got a very high learning curve. Now coming to a situation where we need, we face a difficult situation and need to decide something upon or call for help. Clues pointing towards difficulty ahead includes confusing anatomy, lack of progression with dissection, unexplained bleeding, bile leakage in Calot's triangle, need for excessive number of clips. In all these situations, we must have a low threshold to call for a help. And don't mind if the other surgeon is junior to you, because it is not about seniority which matters most. It's about the, the unbiased view of the situation and suggestion given by the person. So you may have a younger colleague in your department, but even if you call him or her, the chances are that you would be in a better position to deal with these situations. Call for help for evidence of good judgment, conversion to open cholecystectomy. Again, in these kind of difficulties, if we face, our threshold to convert to open must be low and must always be for a good reason to convert. Difficult laparoscopic cholecystectomy remains a difficult open one also. This also we must keep in mind. Please don't make in your mind an easier operation once you convert it to open. Again, even if you convert it to open, please make sure that your mind reads it, continues to reads it as a difficult situation and deal accordingly. So when I say that call for help, it does not mean that, difficult situation in lap chole. Even in open chole, this holds true. Bailout procedures, when to consider it and how to do it. Always ask a question that is it possible to achieve the CVS? If the answer is not sure or no, then you have to consider bailout procedure. Early adoption of some bailout procedures prevents inadvertent injuries. Again, as I mentioned in my earlier slide, that you have to keep thinking ahead of the situations. So here, this is something like that. If you think that the CVS is not possible to be achieved, then you have to think ahead that what needs to be done. And there you can consider bailout procedures. There are 3 options for bailout procedures. Stop the operation and put the patient on antibiotics. Put a percutaneous placement of cholecystostomy tube and definitive cholecystectomy to be planned after 2 to 3 months. To put a surgical cholecystostomy tube placement followed by a definitive surgery after 2 to 3 months, and subtotal cholecystectomy, which is of 2 types: subtotal fenestrated cholecystectomy and subtotal reconstituting cholecystectomy. So I repeat, the 3 options include: number 1, antibiotics, followed by post-operative percutaneous cholecystostomy tube and definitive surgery after couple of months. Second option, surgical cholecystostomy tube placement and definitive cholecystectomy after couple of months. And third option is subtotal cholecystectomy. Coming to subtotal cholecystectomies, partial cholecystectomy term is discouraged to avoid confusion. So we recommend, it has been a recommendation that we should not use partial cholecystectomy now. And 2 subtypes based on whether a remnant neo-GB is created or not. We have 2 types of subtotal cholecystectomies. When neo-GB is created, we call it subtotal reconstituting cholecystectomy. Here what we do, we remove whole of the gallbladder till the Hartmann's, and then we close the Hartmann's using a stitch. So in a way, you are reconstituting a small gallbladder remnant into a gallbladder. The second type is when the GB left open with a portion remaining, which is known as fenestrating cholecystectomy. Fenestrating cholecystectomy is the most definitive bailout procedure. In reconstituting type, the risk of recurrent stone formation requiring a second more difficult completion cholecystectomy is there. And all of us, I'm sure, must have faced that situation and operated upon for completion cholecystectomy. So these are the points we must take care of. And in conclusion, the primary goal for us should be safety first and total cholecystectomy second. Although majority of laparoscopic cholecystectomies are straightforward, we as surgeons must always keep the practice of safety above all and remain vigilant to stay ahead of the dangerous situations. Please don't be fearful of the situation where you have to tell the patients and their attendants that you could not do the surgery and you have converted that planned surgery into a staged procedure. COSIC is useful to minimize bile duct injury, of which CVS is an important part, and safe treatment of difficult gallbladders is definitely possible. Now, having said that, whatever I have mentioned in these slides, I would like to present situations where the videos where you could probably understand all these things in a better way. So first I'm going to show you a small video of what demonstrating the critical view of safety. It's a simplest of the simplest situation.
Sandeep, while the video is coming up, there is a question from Arshi Khan that why head low position? Will it not come in our view as the bowel loops come to the gallbladder area?
Okay. Sir, actually, head low position is no, sir. It's not head low. It's head up position.
Yeah, that's what. I think there was a misprint there. It should be head up and right
Yeah,
side
I'm sorry
up.
for that. It is the head up position and right up position.
The only place where you put the patient in head low position is once you have finished the dissection, especially if you use saline for wash, then you put the patient in head low and right side low so that all the fluid gravitates to the perihepatic area so that you can suck it out.
Exactly, sir. So my apologies for that misprint.
Yeah, please play the video now.
Yes. So this is the one of the easier settings of for cholecystectomy. This is the ICJ. So
we are not seeing the video still. We are seeing your slides only. I think if you stop sharing and then share again, maybe it will work.
Is it visible?
Yes, now.
Okay. So this is the one of the more simpler situations inside abdomen. And this is the IC. So this is the dissection to achieve critical view of safety. I see the instrument is close to gallbladder, and the dissection is the initial part of dissection is the posterior dissection. So we must always maintain this sequence of dissection. The posterior dissection has to be in the initial part of the whole procedure. And once the dissection is complete, you can see that only two structures are going into the gallbladder. Here you can see this is the cystic duct, cystic artery, and the 1/3 of the GB bed separated from the liver. So this is, and both these windows are clear of any fibrofatty tissue here. So this is the achievement of critical view of safety. Now we are safe to clip these two structures and divide them. Actually, sir, the PPT, it is not functioning in PPT, so taking few seconds. I hope I have not crossed the timeline and time of the presentation. So this is again in a cirrhotic patient. So you see here that this segment, how
we are not seeing, Sandeep, we are not seeing the video.
Okay,
please share the video.
Yes. So, sir, is it visible now?
No, we are still seeing only the file folder.
Okay, sir, just a moment. So,
yes,
sir, okay. So here you can see the hanging part of the liver obscuring the area of dissection. So here you need a fifth port to retract this lobe. You see this instrument is put to retract the segment 3 part. And here what I was mentioning there, in situations the Rouvier sulcus gets very close to the gallbladder fossa, and in cirrhotics it is very common. So we have to be very, very careful while doing dissection in these patients. So here it is very important, even more important, to stay almost on the gallbladder. So again, you can see the creation of critical view, achievement of critical view of safety. And once that is done, the cystic artery is being divided, followed by cystic duct. Is it visible, sir?
Yes, yes.
Okay. So this is an acute cholecystitis situation, and here you see this is just for the purpose of presentation that the infundibular technique is being used in this cholecystectomy. And as you see, just the dissection posterior to the cystic duct and artery is done and then divided without achieving critical view of safety. And you can understand how unsafe it would be. So there is no element of posterior dissection here. Only the duct and arteries were dissected and clipped. And here, once you do that, the chances, if at all this duct is common bile duct, then the injury would be there. Very severe form of acute cholecystitis. And in this situation, so here the problem was a very big cystic duct lymph node lying over the calot's triangle, which was obscuring and the area and making it difficult for proper calot's triangle. So first what we did was we dissected the lymph node and then proceeded with the Calot's triangle dissection. Another important situation is that when we have a stone, like in this situation, we had a large lymph node. Sometimes we have a large stone impacted in the Hartmann's pouch, and which make it difficult for us to dissect the calots properly. So you can see here. So in these situations, what we do, we just open this Hartmann's pouch and remove the stone, thus opening the Calot's triangle. All these situations are in severe acute cholecystitis. You see here, now the stone is out and that opening was used for retraction. Another situation is where we have a abnormal cystic duct junction. You see in this situation, the cystic duct is entering onto the anterior surface of common bile duct rather than on the lateral surface. So this made the dissection a bit difficult. So all these situations would be made easy and safe if we practice creation of critical view, achievement of critical view of safety. Another situation is when we have a cholecystopyloric fistula. We have to suspect all these fistulae whenever we have a dense adhesions between the two organs. And you can see here, this is the gallbladder and this is the pyloric area densely adhered to the body and Hartmann's part of the gallbladder. So in these cases, again, the key is to remain close to the gallbladder so as not to injure the viscera adhered to it. And in any such situations, always think of dealing with a fistula. And you see here, the fistula got open. And once the connection is divided, the margins were freshened and the fistula opening was repaired. Another situation is a porcelain gallbladder. The problem with porcelain gallbladder is because of the calcification, gallbladder is very difficult to retract. And in this patient, the degree of difficulty was because of two things. One, the liver was cirrhotic and the gallbladder was porcelain. So what we did was we just got hold of some flimsy adhesions at the fundus area to retract it a bit and then do all the dissection close to the gallbladder. And somehow again in this patient, we had used a fifth port to retract the liver. And you can see it is all very difficult to get hold of the gallbladder. So in these videos tell us first how to manage this situation, and secondly also that if at all these situations are faced and we are not comfortable in our setup to deal with it, it's better to either abandon the procedure or convert it to open if you think you can manage them by an open method. That is all from my side, sir. And sorry for this intermittent delays because the videos could not be incorporated in the PPT itself.
No, I think it was good that we saw the video at the end after understanding the theoretical aspect. So, Dr. Ajay Sharma, he is the Chief of Surgical Gastroenterology, also here. Hi, I would request Ajay to make some comments.
Nice, Sundeep. It was a really very informative and a very good presentation. And I think most of the students must have learned the importance of critical view of safety, because most of the students discuss about a critical view of safety is that they think that identifying just two structures over there is enough. I think the third part is equally more important, that you should dissect the gallbladder from the bed almost at least 1/3, and then the CVS view is achieved. Just wanted to add that it is if you have a difficult gallbladder, I don't think you should always pressurize yourself to go to critical view of safety, because in that you may inadvertently identify the CBD as a cystic duct, because that is all sometimes frozen. So just don't go in that area. Don't be very harsh to yourself that I have to establish that. Rather, either use a fundal first approach, or you may do a subtotal. That may be a more safe method in some of these circumstances.
Yeah. So just a few points which need repetition because they are very, very important. One is that if you have a difficult gallbladder, if you can identify it pre-op, refer the patient to a more experienced person, especially if you are a novice, if you don't have large experience of doing difficult gallbladders. That's very, very important point. There is no harm in doing that. There may be some loss of ego, but loss of ego is better than loss of life or loss of biliary tree or of the patient, and loss of your time and money in case there is a case filed against you. Second is, if you find a difficult gallbladder intraoperatively, so you put in a telescope and now you find it is difficult. So if it is acute cholecystitis, then as Dr. Sundeep said, you can come out, wait for a few weeks, and you yourself can go in. By the time the inflammation would have settled and things would have become easier. If it is chronic cholecystitis, then obviously things will not change. And then probably it is better to refer the patient to a more experienced surgeon. Two more factors. He mentioned almost all the factors which can predict a difficult gallbladder preoperatively. Patients who have had a CBD stone requiring endoscopic intervention, or those who have had acute pancreatitis. So there are a large number of preoperative factors which can tell you both clinical, biochemical, and ultrasound findings. So you must review each patient, especially if you are a young novice surgeon. You must review each patient on those parameters which Dr. Sundeep has mentioned. And if 1, 2, 3 or more of these parameters are present, anticipate that this is going to be a difficult gallbladder, and then either if you are very new, either refer or make sure that some senior, more experienced person is available in case you get into a difficulty. The point which Ajay made, actually we've done that study, one of our students, and we are soon going to present and publish it, that especially in our cases where patients present after months or even years of symptoms, repeated, as Dr. Sundeep said, repeated attacks of biliary colic, previous acute cholecystitis, and all those factors. Sometimes the calot triangle is not only inflamed, not only fibrotic, not only difficult, but it is not there. It is completely frozen. The common hepatic duct has got fused with the infundibulum or the neck of the gallbladder. And in these situations, as we will show in those video clips when we present it, sometimes it is dangerous actually to try to dissect. So you have to anticipate that situation in advance. And then the safest option, as Dr. Sundeep said, the bailout option of a subtotal cholecystectomy. And he was very right in pointing out that we should stop using the word partial, because partial means that you remove a small part of gallbladder, whereas subtotal means you remove as much as possible, as much as is safe. Although way back in 93, when we published, we used the word partial, but now we say that it should be subtotal. So that is a good option, that you open the gallbladder much away from where the CBD possibly is, remove the stones, look at it from inside, and then identify how much of the gallbladder you can safely remove. So that is a very good option. And if you have just very minimal laparoscopic suturing skills, then that is a good option. And that is why the conversion rates in most units are going down. Because today, if you have good laparoscopic suturing skills, the only reason for conversion would be massive, uncontrollable arterial bleed, which you cannot control. So thank you, Sundeep. I think Kulbhushan is there. Kulbhushan, you want to make some comment?
Yeah, good morning,
Please
sir.
Come. Morning. Please
Sir,
come in.
yes, sir. Sir, I was driving, so in between, I'm unable to hear properly. But, sir, I have a comment like in difficult coli. All like if there is difficulty in dissection of calots, so better to go for the either refer to a experienced surgeon or do a subtotal cholecystectomy, but never go for a to do a difficult callus to do a dissection that part, because the situation like a biac injury is very lethal and very morbid for patient in the future. Thank you, sir.
You want to say something? Anand is there. Anand Nagar.
Yes, sir. Thank you, Sandeep, sir.
Yeah.
I want to reiterate one thing which was Ajay sir emphasized. Every surgeon at least should expose the lower 1/3 part of cystic plate from the gallbladder to gallbladder, so we can reduce the aberrant ductal or the interseptal ductal, which is very important content from my side.
Avinash, you are there? Any other participants would like to say or ask anything?
Sandeep, in the meantime, I would say that there is a CVS that is which has been established. So now I call it as CVS Part 1 and Part 2. So the Part 1 has been standardized because the CVS was established for simple cholecystectomies and where you can establish it. Now I say the Part 2, which is more important coming up, is to differentiate between a partial cholecystectomy and subtotal cholecystectomy. We often get a gallbladder in which only the fundus has been removed and the remnant of the gallbladder is there. So I would say that now in this patient, the CVS is you should identify the cystic duct opening. If you have not seen the cystic duct opening, don't close the gallbladder.
Absolutely.
So, Sandeep, I'll request you, we run a separate session on Friday evening, 3 to 4, for colleagues in Africa because they are not able to join this morning session. Although I can see Dr. Vihar Kotecha is there from Tanzania, but many other students. So I would request you to repeat this presentation in one of the Friday evening sessions. Piyush Vashne coordinates that. I'll ask Piyush to get in touch with you and take your time. So we would love to have this repeat presentation for our colleagues in Africa. And all the participants, if you want to read a little more about safe cholecystectomy, please email me, vkkapoor.india@gmail.com. Write safe chole in the subject of the mail. I'll send you the soft copy of the book Safe Chole, which has been published by Celsi. Okay. Thank you, Sandeep. Thank you very much.
Thank you, sir. Thank you, Dr. Ajay and Dr. Anand, for giving me this opportunity and for this live interaction. Thank you so much. I also end up learning few things. Thank you so much.
Thank you.